Hi, I'm Dr. Liu. I'm from Singapore. Actually, my CEO was supposed to give the presentation, but he couldn't make it, so he asked me to come. I have to seek your forgiveness for my voice. I got not a good sleep last night because of the bad cold. Not used to the weather in Amsterdam. Yeah. So, but anyway, I'm glad I'm here. That I can share with you what our country is doing in the population approach to primary healthcare as well as mental care, healthcare in Singapore, mainly in the community. So I'll just give we'll give an introduction about Singapore in case most of you have not heard about us and what our polyclinics do in the Singapore and how we approach the healthcare in terms of integrated care, an example of a healthcare experience in our polyclinics setting. So in terms of Singapore is really a little small dot at the Southeast Asia, and our population is right now about 5.8 million, about 5 million in a very, very small island. It's very packed and crowded, mainly Chinese as the population in the occupying about 3/4 of the island, and then followed by Indians and Malays, and like what we see in the plenary session, our population is really aging. Right now, we have about 9% of our population being 65 and above, but 20 years from now, we will be almost 20%, and this is just a typical site in our polyclinics where lots of people are waiting for their turn to see doctors, and the majority of them are really the elderly age group. And for Singapore, we are one of the busiest ports, and with renowned airports with lots of good food, and this new thing that comes about actually is casino inside this integrated resort. So you have some relevance in the mental health later on. So because of the good food and lots of issues, our principal cause of death is close to what you see in the Western world, where cancer, the ischemic heart disease, and the cerebral vascular disease are top, and all related to the basic cardiovascular risk factors, diabetes, hypertension, and lipid disorders. And likewise, the hospitalization conditions are also topping in terms of the cardiovascular risk as well as complications. Now, in terms of the disability adjusted life years, you can find that the cardiovascular disease occupy 20%, and then mental health is 11%, of which the anxiety, depression occupies about 6%, and Alzheimer's and other dementia is about 3.2%. Schizophrenia is about 2.7%. Every 6 years we will have our national health survey to look at our population, exactly what are we facing with. So you can find that in terms of diabetes, for last year we actually have grown to a 2-digit percentage. Likewise, hypertension and is around 1/4. Obesity has also grown to 2 figures, and one part to look at is also our regular exercise has really gone down, despite our effort to get everybody to walk, so it's still not doing that well. And in terms of common mental illnesses, as I mentioned just now, depression, anxiety tops in the illness we see in the community. And so this is just another way to represent in terms of the disability adjusted life years. The anxiety and depression is two conditions to look at. In our polyclinic setting, we have 9 polyclinics in an island that's mainly in the western and northern part of Singapore. So we have 9 polyclinics being supported by the 3 hospitals that are in relation. Later I will share with you what does it mean. In our polyclinics, we are really pretty busy. Each day we have about 1,000 patients flow through us from 8 o'clock to about 5 p.m. And the population is growing. The attendance in our polyclinics is growing, notably in the 2009 period because of the H1N1. So since then it has gone up pretty much, and we're trying to curb the pop attendance because we are still government linked. We have subsidies from our government, and because of this, our mission is not to have more patients in us. We are supposed to curb it, and so that the patients will go to the private GPs if they can afford. If they cannot afford, we will have our financial means to support them. So following the patient attendance, you can find that for acute and chronic attendances, they are almost equal to each other. Non-morbid are mainly by our nurses doing immunization, developmental assessments, and other screenings. In terms of the age group, you can find that majority are the adult age group as well as the elderly above 65. So that explains why we are dealing with more elderly people. And yeah, so like elderly people with the cardiovascular risk factors. So you can find that in terms of our head count, we are really gaining in numbers in terms of patients with this DH and L. That's what we call it in Singapore, just to lump them together, these cardiovascular risk factors. Our chronic disease load is a bit interesting in our setting. In the distribution of doctors in primary care, we occupy about 12% of the whole Singapore population. But because of the subsidy benefits, the more chronic patients will veer towards us. So as a result, our chronic load is actually almost 50%. Half of the community needs goes to our polyclinics. So because of that, and our good care, we are able to you'll find that our case mix of patients in our polyclinics are getting more and more complex. You can find that in 2009 that almost 100% of our patients have at least one comorbid conditions or cardiovascular complications. So we have an agenda, 9 polyclinics together with the other 9. We have 18 polyclinics in the whole island, trying to approach 50% of our community workload with chronic illness. So we have this nationwide approach to health promotion, early detection, and disease management, where our 19 polyclinics are tasked to work out to benefit our population. So this is just it's just a schema to show that we have health promotion, early detection, and we are concerned about mental health, and definitely want to strengthen our primary care so that we will minimize the referral to hospitals and reduce healthcare costs in our country. So in terms of promotion, the Health Promotion Board works through different areas. One good example are the schools, where they have promotion activities such as providing good and healthy food to our children. At the same time, in the workplace, we work closely with the Ministry of Health and Health Promotion to provide screenings, health promotion activities, and chronic disease management in the various workplaces. In terms of early detection, besides our polyclinics provide screening patients for the important illness, diabetes, hypertension, and lipid disorders, plus obesity. The ministry also allows our GPs, private GPs, to work closely with patients in this management of their chronic diseases, so that their performance can be tracked and also be monitored. And so this is much amount of money that we want to spend in this private education initiatives. And for the mental health, is up and coming for the past 1-2 years, where the government will pump money to enable community health, mental health teams and mobile crisis teams to achieve this national target. Coming to our polyclinics, our aim to have one patient and one family physician. And the ministry is also providing co-funding for our young doctors to take up more higher level of training in family medicine, so that they are more equipped to handle the complexity of cases that they see in the years to come. For our 9 polyclinics in NHG cluster, we have set up this True North concept, where we believe that we have this target to achieve. Although this may seem to be daunting, but this is our aim, that we want to go for 100% dedicated team of care team by our family physicians with seamless integrated care, to have full control of our chronic illness, at the same time to detect them before things get worse. So in terms of health promotion, in our polyclinics, we have various means to promote health, whether it's in terms of brochures, posters, or even in terms of the vending machine where we are providing good healthy food for their choices. And moving on, we will have more of these colorful pictures to attract our patients' attention, so that they know where they can seek help to. And in our chronic care model, we really model after Wagner's concept, which all of you may have heard about it, where we focus on the self-management support with good delivery design and decision support, as well as IT enablement, so that we can have prepared, proactive practice ourselves as prepared and proactive to activate and have our patients informed of their conditions. So in this schema, where we have set, even with discussion with our hospitals and other community healthcare providers, this is the typical setting where we have the preventive care, primary care, acute care, and followed by palliative care. For our polyclinics, we don't cover all these care, especially the palliative segment. So we have to work closely with our community providers in providing hospice as well as the home care to our patients. So this is just an example of how our chronic patients are being looked after in our polyclinics. We screen our patients from when they are 40 years and above, with the detection of the DHL as well as the height and weight. And when the chronic diseases are detected, we have the doctors for assessment, as well as referring to other healthcare providers, whether they are nurses, dietitians, physiotherapists, or even psychologists and social workers if they have psychosocial issues. And with the regular follow-up and progress, to monitor progress, we also include the annual panel of ECGs and tests to detect other cardiovascular comorbid conditions or complications. Moving on, we feel that there are many things that we should be doing to make our services better. As I was explaining to you, we have 1,000 patients passing through our building each day. So there are many, and currently they are more doctor-centric. So our doctors are working very hard each day just to clear these cases. So we believe that with better workflow measurements, so we can allow nurses and non-clinicians to help us in our pre-consult and consult area, so that we can streamline as identify who are the patients who really need to see our doctors, mainly those people with chronic complex conditions. Those with simple chronic conditions, we can consider them as we can use protocols and get our nurses and other allied health professions to go through with them. So we actually make some small tests out of our VSM, value stream mapping, and from our calculations, we believe that if we were to progress in this future state, we can actually save 1/4 of our doctors' attendances to pass on to our non-doctors. So this is just one value stream mapping that we have done in terms of our chronic and acute cases. And for us in our polyclinics, because of the workload, we believe that we can provide as a team of multidiscipline professionals to attend to our patients, led by our family physicians, so that they will attend to more complex cases. For those with more straightforward cases, our nurses can help us to attend to them. So in terms of integration of care, to us, we believe that these 3 C's are very relevant: strong IT system, good network with the other healthcare institutions, and some form of conversion, change of mindset, as you have heard in the plenary early on. How we should have cultural change, how we should have financial change, and other models that currently hinder us from moving on. In terms of our IT, we are still growing, so we have various forms of IT programs to help us with our electronic medical records, our electronic prescriptions, our electronic orders for radiological or the lab conditions. And we even have this teleophthalmology, where the eye surgeons in the hospital can view our patients with chronic visual impairment in the remote setting in the polyclinics, so that the care can be done outside the hospital. Moving on, we are linking all the mini clusters of hospitals and polyclinics together with the GPs under this national health records, electronic health records that we can link on. But this is still the beginning of our journey. We are only starting to link up with our cluster hospitals and some community providers. So in terms of the integration, we have for our 9 polyclinics, we have our mini clusters serving together with a regional hospital. So interactions are very relevant, because for us with 9 polyclinics, we aim to have uniform care and uniform criteria for referrals, where hospitals, they have their own set of criteria. So it's a challenge to work with them to have some uniformity even in this small island. Now coming to this mental health issues that our polyclinics are piloting in the past 2-3 years, how we want to shift mental health service delivery in the primary care. So this is the outline that I'm representing. Yeah. So in terms of the detection of the mental health illness, as I mentioned in the earlier slides, anxiety and depressions are the top conditions, mental health conditions that we see in Singapore. So our polyclinics aim to target these neurotic conditions first, so that we can detect them earlier. And because almost half of our patients are chronic patients, they also come with their own psychosocial issues that we believe if we can address them early, they will not develop other more complicated neurotic conditions later. So this is just an example of why we want to go into depression screening tool. So currently we are testing out these 2 screening tools in our polyclinics. One is the PHQ tool. We just ask 2 questions, whether there's little interest in doing things or whether you are feeling down and depressed. So if they have yes to any answer, they will follow up with the PHQ-9 questionnaire. And for this PHQ tool, we find that there's this good specificity and sensitivity for major depression. So moving on to PHQ-9, there are more questions relating to it, so it takes more time. And for us in primary care, this is pretty new thing. So for the past 2-3 years, we are getting our doctors, our nurses to practice asking these questions. Being Asians, I think you may realize that we are more reserved. Our patients will not be willing to express their psychosocial issues. Yeah. So it will be a challenge even for them to declare, oh, I'm depressed, and to work on. So it's really a learning journey for us to identify them through other psychosomatic disorders, or just simply having a good engagement process with them. So for us, we developed this health and mind team, where we have our doctors trained in more mental health illness, together with the psychologists, social workers, and our nurse as a case manager. We attend to these patients so that they will be able to, we detect them early and sort of help them to overcome their psychosocial issues. So we believe in this, definitely this holistic team-based care to attend to them. And in this more like a complicated slide, we have the issues where the nurse can attend to the majority of patients. If the issues get more difficult, our doctors will intervene and even refer them to the hospitals when needed. So for these 2 years in one polyclinic, this is what we have found, that we have about almost, in terms of headcount, we have a quarter of them, and half of them expressing anxiety or depressive disorders. Most of the psychotic illness we will have referred to our mental health hospital. So moving on, this is what we want to go on, not just for chronic illness, but also for our mental health illness, that we need to build up our doctors as well as multidisciplinary professionals in terms of handling complex issues, mental health issues, with good clinical safeguards and audits to check on our work. a good IT enhancement to enable all of us to be linked together, to communicate one another. Definitely financial viability, because we are, in our country, we believe in co-payment, so we need to make it very cost-effective for our patients to find a benefit to come to us. And finally, branding and marketing, because in terms of the nature of our population, we need to have some form. We have more forms of communication network with our patients and our population for them to approach us, and of course for us to detect them earlier. Yeah. So this is what I have. I think I've achieved 25 minutes. Yeah. I think the questions will be asked later. Yes. Yeah. Okay.
Thank you very much indeed. I will invite our colleague from Sweden to do the next session, including sorting out the mic.
Okay. First commission.
Yes.
I can do the presentation.
No, we push that. It's okay. Yeah. That's the one.
Perfect.
Okay. Is that?
No, it's not okay.
Okay. Yeah. Okay. We start like this. My name is Joakim Edvinsson, and I'm a nurse working at Qulturum, Innovation and Development Center in the County Council of Jönköping. And this is the man without the mic.
Yeah. My name is Jesper Ekberg, and I'm also at Qulturum. I'm a public health, have a master in public health as well, so it fits well into this kind of preventive session, I think.
Mm-hmm.
Yeah.
So we should talk a little bit about the intervention amongst that we are spreading in Sweden and the ways we are doing it. And it's very interesting when you all listen to Maureen Bisognanu, and she talked about the elderly population and preventive care and so on. And so we are very much into that presentation as well. This is the county we are from, and country. The County Council of Jönköping is 3 hospitals and 13 municipalities, and in the south of Sweden. And we have about 34 primary care centers that we own. Then we have about 20 private as well, and about 10,000 employees. And our county council, this is a very messy picture, but this says that we work with quality as a business strategy, and been doing that for quite a long time now. So we work a lot with system measures and strategic improvement areas and balanced scorecard and system mapping and so on. So because we think we have to change the whole system at once. We can't do it bit by bit. And this is a little picture that shows that we are doing some good results about efficiency and clinical quality and cost. So we are doing quite well in comparisons. So that's our background, you would say, in this. What we are talking about now is this senior alert. And actually, it's what it sounds like even in Swedish and English. So it was a very good name for us. It's a national quality register, and those who are not from Sweden, you know that we have about 90 national register, and still counting. They are increasing more and more every year. And there are different kinds of registers in Sweden. We have those diagnostic registers, for example, diabetes and stroke registers. And we have intervention registers like hip plastic operation and hernia operation and that kind of intervention registers. And they have meant a lot of for the quality development in Sweden, and they are a base for research and quality improvements, both in the bigs in Sweden and also in the clinics, the hospitals, and so on. Those are very medical based, and almost every register has a physician or the medicine approach to it. So Senior Alert is a little bit different. We are doing some it's about for the primary care and for the municipality care as well as hospital care, and that is quite unique in Sweden. We have the palliative register for palliative care as in that kind, but it's a very, what you call it, it's not so they're not so used to registers in that kind of settings. And Senior Alert is a process register because we think that the preventive work is the process, and in your presentation you also have this process by risk assessment, screening, and then taking actions and then doing the follow-up. So that's very similar. So we built this as a process register. And the target group, we sometimes discuss what is the target group for these seniors, because we have a lots of senior, and we could work with health promotion in the population, and we could also work with care and treatment of injuries like this. But our focus for this is when you are in contact with health care or social care, like in nursing homes and that kind of places, and you're at risk for falls, malnutrition, and pressure sores, then we have the focus on this group in the register. And this is the process that we have built the register on, and this is what we are spreading in Sweden now. It's about identifying risk and do risk assessment and analysis of the causes, plan and execute preventive actions by team dialogue and responsibilities in the team, and you have an evaluation and learn from the results, and that also should be team-based and helping to the next step. So this is we call it, we invented a new Swedish word, care prevention. That's not a Swedish word, but I translated it. Care prevention. It's about preventing unnecessary care, you should say. A pressure sore is not necessary in most cases. Just for a glimpse, we're not going, this session is about spread more. We have a session tomorrow for an hour, so if you want to learn more about deeper into Senior Alert, you can attend that seminar. But we have this simple structure, evidence-based and quantified by risk assessment tool, like the short form M&A, the modified Norton scale, and downtoll for risk assessment, for example. And we have two purposes, and that's increasing quality of life. Maureen talked about Antonovsky and the okay, you know what I mean. It's a different hard word in Swedish as well. Yeah. And also decrease the unnecessary harm and illness. So we have to work with both things to strengthen what works and try to reduce what could be risks and harms. So that's...
I could also say that since we're launching this registry now in all municipalities in Sweden, the focus will be more, of course, on healthy lifestyles and more that kind of actions, which is really important for us to take into the registry, because so it's more of a cultural change we can see now. That we explain the prevention actions more in a healthy way now than we did 2 years ago when there were only hospitals in the registry. So it's a learning process there. Yeah.
Yes. Moving on. And this, we have learned that equal care does not mean that every staff member knows the same thing, but equal care means that every staff member sees and acts in the same way. And that's very important that's why we have this process very standardized. So it's not depending on who is meeting the patient or the elderly. We don't call them patients, we call them elderly or persons. And this registers helps to ask some structured questions about this. And these are some results from a county council, which have been working for a long time with this. And you can see, we think that the systematic is very important. So you have to be, if you can't find the persons with risk, you can't take preventive actions. That's our hypothesis. And this, you see, we are quite stable over time in identifying risks amongst these. And if you have a risk, you should have an action plan, or you have a preventive action, and we're tracking that as well. And that's why we call it a process register. We're tracking that the process is in place. So this is some good examples from county council. But we also want to, when you talk about quality register, people think, well, it's a lot of data and, you know, figures and lines and so on. But it is, of course. But we're trying to use those data in a more proactive way, so you can see, okay, this is how good we are this month, but what are our next steps? And this is a screen from one of our ways of presenting data. When you see, I'm sorry, this is of course in Swedish. We haven't done the English translation because it's right in the system, where you have the people on this. This is a nursing home, and you have persons there that now they are unidentified, but you have them there, and you see they are very in green. They have a risk assessment the last six months. They are not so good in doing the causes analysis. They say they have a lot of red in the fall and the pressure source, trycksår there is pressure source, and malnutrition, so you can have a glimpse of what are the risks here. And then, do we have preventive actions there? Yes, I could put in falls. No, they had quite a lot of red there, and so they could be improving. And do they have any falls last months? And do they have any pressure source? And how is the weight changing? So just in 3 seconds, they see, and the more green you have, the better you are doing. So this is a way of presenting data, which we are quite proud of. This is also a prize. We won the Golden Scalpel in 2008. It's a national medical magazine, you can call it, for innovation in healthcare. And they listed what Maureen said: prevention is important, the aging population is important, to transform or have evidence-based methodology into to practice is important, and so on. And the online registration is very important, to have a system for this and so on. So we were a little bit proud of that. And some success factors we have is senior leadership must be interested, of course. We have to work with the teams. I was struck by what Maureen said about 2.5 people around the patient to 19.5 people. You have to really focus on the team more, and I think this you have to be persistent. You can't do this by on a weekly basis. This is years you have to work on. And the quality register is not the thing, but it helps us to keep, you know, if you do a project, you go up like this and then you go down like this. But if you have a quality register, you can see, okay, we are going down now, we have to do something. So we can track this, and that's a new kind of data we have. So Jesper, we got a message from the Swedish Social Ministry in March 2010. Yeah. What was that all about?
I know. I felt like Bateman for a while when the red phone rang, and Joakim rang me and asked me if I was ready for this mission. So I'm actually the project leader for the national spread of Senior Alert. So we're now right in the middle of this. At first it was a campaign, you could say, but now we're more of a learning community. I think when it comes to, we have to do the right preventive actions, and we have to follow it up in a good way. And that's what it's all about. It's not about only doing the risk assessments or putting the data in the register. It's about making the life better, of course, for the elderly in Sweden. So the mission I got here was actually that we should do it nationally, and we have to use quality registers to see that the work is being done as we wanted to. And a 3 years period, and the first year we had the goal, the vision almost, that with 75% of all the municipalities should be in the quality registry the first year. And I got the message, in March, so it was so it was a tricky one. But and we also, along with on this trip, we have the palliative registry, of course. That's a very good thing, actually, that we have all the way, the elderly people, but connected to the palliative care, and also now as we look into the elderly's home. So we have the whole journey there. It's important to say.
Healthcare is not a visit, it's a journey.
Yeah, I know, it's a journey, yeah. And this is one journey, as you can see here now. We got I think it was approximately 70% at the end of 2010. So it was a really intense time there. And now, as you can see, just a few days ago, we had 226 municipalities in the registry. So it's been a big national spread in a short time, and that's what we're going to tell a little bit more about. How did we do that? And we believe that it's two ways, because the government also gives a small amount of money for healthcare professionals for doing this, but we also saw that that's not going to be the thing to make this last for a long time. We need to build another kind of learning community. So this is how it looked in the 20th of September 2010 in Sweden, with the municipalities map. And now in the 24th of March we can see that all the green municipalities, they are connected and mostly using it as well. I'm going to show that. And the yellow ones are the decision taken, and they're going into the... But then you can see the pink or the red dots here. It's mostly connected to the what we call it, the big cities in Sweden. So there are a lot of caregivers there, and it takes a little bit more time than we can do it in 2-3 months. But we're getting there. And this is the north of Sweden as well. And if we look at the county councils, the regional actors, we're on a nice trip, I think. But as you can see, it's Stockholm, and it's down in the south there, Skåne, and also Gothenburg and around there. We need to, that's the big mission for this year, to get them going there. But as I said, the spread is not about, to fill in the registry. If we look at the organizational viewpoint, the first level is that we need to start the registration. We need to do, the risk assessments. That's the first question people get. But then the next step is, how can we get this structured flow in how we work in everyday life? Risk assessment. How do we actually know that the preventive actions are relevant? I think that's a very crucial question, but because it's often talk about preventive work, and then you just use it and you can do it any way you want to, but we need to do it in a relevant way. And then you need the team action, the structured huddle, as she said. Yeah. And then the next level, that we can see, maybe 20 or 30 municipalities in Sweden now has reached level 3, where they actually reflect in the team about the results, and they use the data in a meaningful way to actually improve the preventive work. And that's the big challenge, I think. Over time now you can see the number of units connected to the registry, and if we get this layer on, then you can see that the first year here we had a lot of, as I said, a campaign about why should I do this? Why should I put time on putting into data? It takes some time to put in all the numbers in the registry. But now, as we move into this year and this spring here, people know why, and they really trying to building the right preventive process. And that's another support we're now giving. It's more about getting out there and have workshops with teams from healthcare and municipalities. How does it look today? How can you improve that process? And as we move on to next year, it's going to be a lot about the system. You know, it's the same people that move around in our different systems, and we need to analyze results on that level as well. So it's an interesting journey in a national spread way that we go to these three phases. We can see that very clear. That it's about why, then how, and then getting the big picture of it and how we use it in everyday life. This is also an important picture, we think, because it's about using the registry from the individual viewpoint, that we actually, the level 1 is, I know that a risk assessment is done. That's a good way to, but if nothing happens after that, then it's a risk not to, then you feel, okay, I got a fall risk, but nothing happens. Then you get scared and you know, stay inside and you stay in bed, and then you know. So it's really important that we take the level 2 step, that we make preventive actions together with healthcare professionals. And the most important, I feel the difference actually. And that's a tricky question, because how can you feel the difference in preventive work? Can you feel that you skipped a fall, if you know what I mean? You can't feel that, but you can feel that, oh, my balance has improved. Or my appetite has gone up. I like eating nowadays. You know, you can feel that. And for the patient's viewpoint, you can say, oh, you know, we now decreased the risk for a pressure source. We could say that, but it's better to say, oh, it's good that you move more nowadays. How did you manage that? How can we support that kind of lifestyle? So it's important, I think. 5 minutes, yes, that's perfect. So if we summarize just the whole picture of using Senior Alert and the quality registry, we can see these 4 processes that we try to get out there in the country to work with. And the first one is very much about what Joakim said, that how do we use the registry in a meaningful way? We have the IT support, and you get the web guidance. That's a really good tool, that we have live meetings on the web where people can join for an hour, and then they learn how to register in the registry. So, and we have Senior Alert coaches on that one, so it's important. But also we need to work with the process, of course, and that's very, very much a workshop thing, that we really need to meet people and that they need to work in a structured way with that one. And then, of course, we have team and improvement breakthrough series that me and Joakim have in Sweden, with lots of teams that they try to make this as an improvement journey, of course, with using the test and the PGSA cycle and so. And then, of course, reflect on results and learn from data. So I think this is the kind of a journey that we're into, that we have focused on the register and how we work in the process this year, last year, but now we need to move into the next step here. The last minutes here, I'm going to talk a little bit more about the Senior Alert coaches, because we could see that if we were going to reach 75% of the municipalities in less than half a year, then we couldn't use informations and conferences and so on. We need to have live people out there in the whole of the region. So what we did was that we recruited 25 Senior Alert coaches full-time for 6 months, a half-year mission. So we had 25 people in different teams, as you can see. I'm the the logistic leader for those people. And it's been a great journey to how can we support a nation spread using coaches in all the nation at once. So we have a great network where we use mainly web meetings, phone meetings, of course, to keep the work up and to get people going there. So what they actually do is that they inspire people in elderly care to join the register, but also to begin the preventive process, of course. And they're out there to visit people and talk to the leaders and how is your situation here? How can you use this in a meaningful way? And I think that's been a very crucial part of the spread work, that we have these human people out there in flesh and blood, you know. And the last picture I think here is very much about what kind of tools can we now see that we've been using. It's very much about, of course, the field operation, that the coaches, they need the materials, you know, the pictures, forms, contact lists, movies. So we have a kind of a toolbox for the coaches that we use. And they, of course, improve it when they use it, of course. We can see the importance of using maps and key measures from the register to follow how the spread is going on forward. And the communication is, of course, very important in a national perspective, that we have weekly phone meetings with the coaches, that we have web meetings, and we also have a web forum that we use a lot, that we and the coaches and so can put on frequently asked questions and so on. So it's been a great journey, and what it's all about, I think, because I've been working a lot with prevention, it's very much about equal care also when it comes to prevention, because it's so much about personal interest still. As soon as we talk prevention, I've studied 10 points in healthcare. I can take that. Then it should be more and more equal, you know, and then we need this kind of registry to know that everybody, not some, but everybody are doing the right preventive actions out there. So it's, and we're still on the trip, so we'll see what happens. Thank you very much.
Thank you very much indeed. I didn't need this one. It's true. Now we have our last presentation from England this time. And then we'll have some questions and thoughts at the end.
Good morning. My name is Michelle, and I've been asked to speak to you about how we've started to transform community services in the UK using quite a structured framework for improvement, both quality, safety, patient and staff experience. I do have some handouts if you want to take those at the end, because there are a couple of slides that you need to actually see them on paper full scale. Okay. Oh, sorry. Is that better? Thank you. What I intend to do throughout the presentation is just to give you a brief overview of Nottinghamshire community health, because rather than do something on a national scale, trying to change something nationally, this was a smaller scale project looking at how we can improve the services we provide in the community. I'll give an overview of the productive community services, which is the framework that we use to engage and to take this transformation forward. And then I'll talk about the challenges and the benefits of implementing the modules. Nottinghamshire Community Health, we're the fourth biggest provider of services within Nottinghamshire, and it is purely community-based services. So it's those services that prevent patients or the population having to go into hospital, or once they've come out of hospital, it's how do we stop them from going back into hospital. We have a diverse range of services, from district nursing, adult community care, children and young people services, therapy services, and specialist community-based services. Each of them have got very, very different approaches to working. Some are appointment-based and some are unplanned activity. And they have very different expectations of what patient-facing time actually means, and I'll explain that terminology as part of the presentation. Because we are community-based also, we provide our services from a range of different venues, be they schools, be they health centres, the patient's home. We do have some community hospitals. And these are the things that could give us quite significant challenges when we're looking at productivity, not just understanding what our services do, but then trying to transform them and make them more productive and make them more efficient. In addition to the diverse venues in the portfolio of services, we have what I think quite embryonic information technology, and that was one of the hurdles we had to overcome when we were putting the productive community services into place. Our staff always say to us they feel like they're feeding the beast and they're getting no information back to help them develop their services. In addition to that, but not specific to community services, we found very, very quickly, which was a surprise to us, that we needed to do some work with our middle managers. We found out that our staff felt they needed to ask permission to make changes, where we as the executive team felt that they had that permission, but it wasn't translated to the staff, and so we had to overcome that blockage. The additional challenges for us during 2010 and 2011 were the transforming community services, which is a concept in the United Kingdom where they seek to make certain efficiencies within the community services. We all know internationally there are issues around financial constraints, and we are finding that there is more and more activity going into the hospitals, and the services now are looking at community to try and stem that wave. So there are issues and at one point they were saying that there are 20% efficiencies that could be made in the community services. However, we work in the community services couldn't see where that was coming from. But that taught us that we needed to understand more about the services we were providing. Also, we had a financial challenge, quite a large financial challenge within our organisation. We had to find the tune of £10.6 million. And I'll tell you something, there's nothing about financial constraints that really focuses your mind. And on top of that, there was the TCS program, which meant that our services, our community services, were looking to be integrated with existing organisations. And on the 1st of April, Nottinghamshire Community Health became integrated with our mental health organisation locally. So we've actually changed as an organisation. So you can imagine the constraints of diversity of services, diversity of venues, plus these added national constraints make it very, very difficult to understand what your services are doing, and then to start eking out efficiencies and productivity. But I do, as the presentation will show, it did focus us, and I think we're really, really proud of some of the things that we've actually achieved. So what is the PCS program? It delivers productivity and quality improvements, and it's based on lean methodology. But it's the lean methodology which has been made to suit the healthcare situation, because lean is always about productivity industry. But within the PCS, it keeps the patient at the focus. And the idea is that essentially any time or any productivity gains is about releasing more time to care. And that was one of the things we found that we had to instill in our staff, because they were concerned this was a cost-cutting exercise. It was something we wanted to do to reduce the need for so many staff. But in actual fact, that's not what we wanted to achieve. We wanted to realise that staff had more time to spend with the patients. It gave us an opportunity to link our strategic objectives to the operational delivery. So it gave us a bridge from the executive speak down to the frontline staff, so they could actually understand what it is we were trying to achieve, and keeping the patient at the focus of everything we do. And I think one of the remarkable things is about empowering and involving the frontline staff and actually giving them that permission to make the improvements which they seek. They have the answers. So what did PCS mean to our staff with NCH? Once we started on the journey, we asked them to come to us with their idea of what productive community services meant, and this is what they said. Enabling frontline staff to transform their services, improving the experience for both patients and staff. And they are really, really enthusiastic about this, and when we go and walk the patch, when we go and talk to the staff, they hold this ethos close to their heart, and they do believe that they themselves have made the differences to the patients and improved the staff well-being. This is what productive community services looks like. basically you decide for yourself within your organisation what a team is. So it's a team around a group of patients or a patient. And then you work through each of these modules, starting with the foundation, going through onto the planning, and then onto the delivery modules. And once you've gone through all of those modules, you should have what they call a productive community service. And as I said before, it is based on lean methodology. Within Nottinghamshire Community Health, we'd already done some work on implementing other productive toolkits. We'd done the productive leader, and we'd done the productive ward, and also the productive community hospital. So that enabled us to understand the lean methodology and maybe make the working of PCS a little easier. For myself, as one of the executive leads, it enabled me to understand the frustrations and some of the struggles which the staff then had to go through as part of the PCS process. We worked with the Institute of Innovation and Improvement, who launched the Productive series, and we were invited to develop and test the modules with them before they actually launched the product in October 2009. And it's still in progress. It's a gradual implementation of the modules across all of the teams within NCH, and we're still in that process. But what I want to share with you today is some of the learning that we've realised. The first module talks about a well-organised working environment. And really, this is about putting the basics right. And if I say to you some of the things that we've done, you'd automatically assume that they were being done anyway. But sometimes you do need an objective observer from the outside who can say, hang on a second, hold a mirror up to what you're doing and enable you to stand back and think of things differently. What this module did, and it's the first module, it really engaged our staff. There were some challenges that we had to overcome. Primarily, they felt this was something about cost cutting. We were trying to impose something on them. We then had to go in from that to then managing their expectations, where they wanted to suddenly do everything. And we almost had to walk with them to say, only try and change the things you can change. And again, it was really about giving them permission to make the changes and overcome some of the concerns that the middle managers presented. And that was about the control. I mean, the keynote speaker spoke about this moving from control and command to collaboration. And I can honestly say that within this module, that's certainly something that we found. The benefits, as the first module, very quickly staff were engaged, and they own the module because the well-organised working environment is about decluttering, housekeeping, basic housekeeping, making sure that you can get your hands on the materials that you need to go and do your home visits. We did a walk-in exercise where we looked at how long it would actually take for you to get all the instruments that you needed or all the items that you needed to, for example, do catheterisation at home. And then we streamlined those processes. So it was getting rid of out-of-date stock. It was making sure that we weren't renewing the stock unnecessarily. So there were some efficiency gains in terms of money, finances, as well as the time for staff as well. And staff really, really engaged with this. They found that it did improve their work environment. It created a safer environment, actually, as well. And it improved the stock control. And what we saw in one team was replicated throughout all of our teams within our organisation. Knowing how well we are doing, our colleagues previously spoke about data and staff feeling inundated and having to input data all the time. And this is certainly one of the modules which is quite data intensive. But what it does do is that it puts the patient very much as the focus of everything they are doing. It gets the team to start to understand staff morale in the team, what are the things that make the staff tick, what are the things that turn the staff off, how do patients actually feel about the services that we're providing to them. And what we did as part of this module is audio tape some interactions with patients and take those back to the team so the team could actually hear what the patients felt about the services that were being provided. And sometimes there were eureka moments, actually, and it made the staff engage more with the patients. And they really felt a lot of benefit from the interviews. Patient status at a glance. This is basically whiteboards in where our staff are situated within health centres. It's the team identifying who are the priority patients on their caseload. So for our adult community nursing staff, it might be those palliative care patients, or it might be those patients that are spoken about that have specific risks like pressure ulcers or falls. So it's a way that when you have got a number of staff working around a patient, it's making sure that everybody is attuned to which patients are the most patients at risk in a caseload and being readily able to identify them. It gave us an opportunity also to streamline handovers. Because you've got the whiteboard, it focuses everybody's mind actually. And it was quite interesting to note how quickly teams took ownership of making sure they were all there for the handover, that the handover was a specific time and only lasted a specific time. And we found that we actually shaved off a lot of time, wasted time, of people having to go back, get further information, etc. And again, it was a live piece of work that the staff themselves took ownership of, and it wasn't something we imposed on them. What we had, again, we spoke about management control. They were concerned about confidentiality, having patient information up on the whiteboard, but there are ways of overcoming that. And one of the things that we found in doing the Productive Community series is that you really need strong leadership at the forefront. So if there are any blockages, or if you do have difficult middle managers who don't want to, who would rather resist, then you can overcome some of those blockages on their behalf. And as part of the process that we went through, we did some work with the middle managers so that they didn't feel too concerned about what we were asking the teams to be able to do. Managing caseload and staffing, this probably was the module that really started to wake up our middle managers. It's the one they got more enthused about, because what we started to do was to look at actually how do the teams function and operate. What do the caseloads look like? What is the staffing against those caseloads? And how are the staff using their time? And as I said, the managers got really, really enthused about that. So the prior anxieties with the other modules kind of got alleviated by this. What the teams found with this information is that there was a bit of rivalry between the teams. I'll show you some of the graphs in a minute. But what we started to do was measure patient-facing time through looking at what is the total allocated time for the teams, and what is the total out of that time, what is the time that could be done using for clinical face-to-face contact with patients. And these are some of the graphs. And again, they're in the handout, so you'll be able to see that. Now, unfortunately, the wording at the bottom is slightly aligned, so I'll work across with you. The blue score shows you the actual total contracted hours for a team within a given period, which is a week. And then what we do, we shave off any time related to annual leave, sickness, and any other training, general travel, supervision, anything that's not related to clinical time. What we then do is look at, having taken all of that time out, what is the total non-patient facing time that we've got to play with? Okay, so we take out things like administration, we take out anything that's related to not clinical activity, but paperwork, etc. And the green bar then shows you how much clinical time we've got left for the team to play with. So this is, okay, having taken out vacancies, annual leave, general training, what time have we got that we can allow to have clinical facing time with patients? Within the green score areas, you then have time for record keeping, time for clinical travel, because what we had to appreciate, because of the way that our services are, we couldn't discount travel totally, because then if you discount travel, then you're not going to have that patient contact in the first place. So we had to take that into account. And what you're left with in the light green is the actual patient-facing time. What our teams then did, we were able, with information we've got, we can track how much patient-facing time each of the teams were actually utilising. And when we started our journey, we were about 27% in one particular team, and we're averaging about 35% at the moment. So we have, through efficiencies and productivity gains, we have increased the patient-facing time. And you do find that all of our teams now are almost in competition with each other, because they want to try and eke out those inefficiencies. It could be inefficiencies in travel. We found that teams were crossing themselves in travelling to patients' home or to clinics, eking out some of those efficiencies to try and see if they can improve the patient-facing time that's available. So what's been the benefits of putting the productive community services in place within NCH? What we have found is that we have hidden leaders. We always say this, but this has really proved the fact that in all levels of our nursing staff, we have hidden leaders, and they rise to the fore. Our community staff know the answer to a lot of these questions. When we're looking, they come to work, they want to make things as good as possible for the patient. They want to work efficiently as they can. They don't want to work harder, they want to work more intelligently. And they usually have the answers for that. But it's giving them the permission to do that, and that's what PCS has done for us. It has improved patient satisfaction, and it encourages that patient-staff interface. The staff that have been through this programme aren't scared to ask the difficult questions and aren't scared to have that interaction with the patient, no matter what the response might be. And there is a greater understanding of the patient's perspective. And what we've done in utilising the PCS, we've also looked at things like our complaint rates, our incidents, etc., so that we can triangulate all the information that we've got, so we can get a really broad picture of what our community services are providing. And staff are really positive about the impact on quality and productivity, and not just efficiency. They now do believe us when we say it is about releasing time to care. When we look at, we can't get away from the fact there will be some financial gains, and there's no two bones about that. But that's not impacting on the patient-staff interface. So when we're looking at our working environment, we may get some efficiency gains, but at the same time we've improved safety and we've improved the quality. And we're now starting to get really, really useful data. And staff at one point where they weren't satisfied with the information they were getting from the IT system, the information technology systems, are actually now feeding that information, knowing that they're going to get information back that tells them how their teams are functioning. These are some of the outcomes that we've had to date, and this is just one team. So you can imagine if we take this, when we've taken this across all of our teams, these will be magnified. In terms of our working environment, we've saved 25%. There's been a 25% reduction in stock holding, and that's a financial gain. We've standardised the measures for patient satisfaction and patient-facing time. So we understand now, and we all work to a common definition of what patient-facing time actually is. There's nothing about penalising or saying you have to get a particular percentage, but it's what you can achieve within your team, and that's put in the context of how you're working. Because of the patient status the glance board, we've had a 30% reduction in daily updating meetings. So staff can do more visits, staff can do more of the interaction with patients. Within the caseload management, we've had a 7% increase in patient-facing time. Going on to planning our workloads, we've seen a 9% reduction in travel time. And because some of our areas are quite rural, what we have done is invested in some sat-navs for our teams to save them having to cross each other and to get to their allocated destinations a lot quicker. And working with key partners, which is the bottom one, we've found that we're doing some work on this. It's still quite embryonic, but we've realised that if we can work with our key partners better in terms of referrals, then we'll probably save about 2.5 weeks per year in unnecessary visiting. In implementing PCS, what I would say to you, I think it's a well worthwhile. I was a little bit sceptical at the beginning, having gone through the productive leader as well. That was quite tortuous. But at the end of it, it is quite hard going to start with until you understand lean methodology and what it's trying to achieve. But then when you start to see what you can actually gain out of it, it's quite an exciting process to go through. But you do need the organisation to show very, very strong leadership, and you do need to be committed, especially when things may not go as well as they should. So staff need to understand this is the vision, and it's like any change programme, not veering off that vision. And being able to say to staff, if there are things that you can't achieve, and it might be something really, really silly like ordering a piece of equipment, then we'll remove the blockages. We found out as an executive team that our organisation was quite bureaucratic, and that was an eye-opener for us. But we were able to get rid of some of the blocks that some of our staff were encountering. Financial constraints actually do act as a positive driver for improvement. We were all focused, and every single one of our staff, be they clinical frontline, managerial, etc., would be able to say to you that we had a focus for the year, which was we needed to gain this 10.6 million deficit. You do need the team and management focus and commitment, which is what I said before. Preparation is the key, so you actually need to put the work in to realise the benefits. But actually, once the clinical teams are given the permission to just go ahead and make the changes, they actually flourish, and we have found that, and that is the same as it is today. So I suppose in summary and conclusion, what PCS has done for us is held up a mirror to our organisation. I think we thought we knew everything there was to know about Nottinghamshire community health, but in actuality we didn't. So whilst we were seeking to make some productivity gains and some efficiency gains, we actually had to understand our organisation in the first place and the wealth of skilled and knowledgeable staff that we had in place, and again giving them the permission to make the changes. It's enabled us to set a benchmark so we can now measure our improvements, and we've never been able to do that before, not with evidence-based, to be able to say this is how the team operates, this is how it functions, this is patient-facing time, this is the amount of time staff travel. And what the teams have done, they've used this information to do silly things like make sure not everybody's on annual leave at the same time. So they look at the information they gathered, they look at training, they look at the vacancy, they look at this intelligent information to make sure the teams are streamlined and are effective throughout the year, because we do have blips where everybody's off and etc. It does improve leadership capability at all levels. And what it does, it encourages a corporate rigour and discipline in understanding the services. And for us as the executive team, getting out there and actually understanding what it means to be a frontline staff day to day. It strengthened the connections between the team and the corporate management. We set up a steering group once we were aligned onto the PCS programme, and the steering group had our managing director, ourselves as executives, but also the frontline staff that were involved in implementing the PCS, and everybody had an equal voice. And I do believe it is a really, really good framework for transforming community services. It's certainly doing that for us. It is a journey that we're continuing on, and we are all engaged in it and we'll be taking it forward. Thank you.